You're live, Chair.
Okay, we're ready to go. Okay, it's now 11:29. I'll call the meeting to order. Welcome to the Grey Bruce Public Health Meeting for Friday, March the 3rd. And I want to apologize to all the board members for our delay, but as I mentioned earlier, some of us were involved in an opioid emergency meeting prior to this that went a little longer, but I'm hopeful that the direction that was given from it will help out during the crisis that is currently ongoing, and that some direction from that meeting will help solve issues in the short term as well as the long term. Kaylee, I'll now ask if you could do the roll call, please.
Yes. Al Barfoot.
Present.
Brian Milne.
Yep, I'm here.
Helen Claire Tingling. Thank you. Chris Peabody.
Present.
Kevin Eccles.
Counted for.
Kenneth Craig.
Present.
Ian Boddy.
Present.
Sue Patterson. Present. Luke Charbonneau.
Here.
Nick Saunders.
Here.
Thanks, Kaylee. I think we've got full attendance today. Next on the agenda then is establishment of the board executive committee. I guess this is just something that we maybe should have done the last meeting and missed. But through our policies and procedures, the executive committee is comprised of the chair, vice chair, and an appointed person. And we technically are still under the governance then of the past executive, but with the change of chair and vice chair, we need to move on from that and establish the new executive committee. So Kaylee, do we have then a motion prepared, or we haven't had a chance to speak about this item just that's on the agenda, but I wasn't sure how we wanted to proceed governance wise.
Yes, we can have a motion if we'd like.
Okay, we should be referencing through our policies then, so that we are adhering to our own policy on that. Maybe you want to do that now, or do you want to, and we can do that later in the meeting then?
We can do it later in the meeting if you prefer. We can ensure if you follow policy.
Sure, I think that's probably a preferred way to go that way. So next then on the agenda, we have any amendments to the agenda? And seeing none from anyone, now I'll ask for an approval of the agenda. Can I have a mover to move by Mr. Eccles, or a seconder for the agenda? Luke Charbonneau, all in favor? That's carried. Next, declaration of pecuniary interest. Does anyone have a declaration of pecuniary interest on the agenda that's before us today? Seeing nothing, then we go to the adoption of the minutes. So there's two sets of minutes then to approve: the revised ones of December the 16th, as well as the past meeting minutes and of January 31st. Everyone's had ample time to look over those. So I know you had brought the issue forward, Luke, regarding the December 16th minutes. They've been revised. Are you okay with the new wording? It was just basically a cleanup from the in-camera to the regular set is really what needed to be clarified there.
They've only got the January 31st minute. But honestly, Mr. Chair, I didn't see the December 16th ones.
They're in the in-camera.
They're in camera, they're not open. Or are they here? I've only got the one set, and I never saw the December 16th one. I didn't know they were coming back, so.
They were in the package that was sent out. I just reviewed it actually before I got on this call now. There was the 2 sets of minutes in the package that went out.
I must have missed it. Very sorry about
No.
that.
Yeah, no problem.
Hopefully you can. Will be considered now. We can't approve now. For Mr. Chair, are we talking in camera minutes?
No,
Because we won't-
just
we're not-
the regular minutes on on the file that was sent to me, like for today's board meeting. The December 16th minutes were in there, as well as the January 31st minutes were both in that package.
Then we have
Just a question in that regard, did we not approve them as amended at the January meeting? We didn't approve
No.
them?
They were not.
No,
Okay, so there we go.
We'll see.
Let me pull that
I
up.
see the drafting cameras here, but I didn't see them.
That's, yeah, I'll pull it up.
okay. So can I have a mover then to adopt those 2 sets of minutes in the December 16th as amended and the January 31st ones? Moved by Mr. Craig, seconded by, my screen just changed there. Warden Peabody, any further discussion then on those minutes? All in favor? That's carried. Okay, so next we move down to 7 under the correspondence and news releases. So the first is the Board of Health Order of Council appointments.
Mr. Chair, can you the
Yep.
correspondence, this time we will be with me, there are a number of correspondence. The first one is a letter from Alpha, which is Association of Local Public Health Agencies, the premier to emphasize the importance of approving provincial nominees to the Board of Health. There are a number of applications throughout the province, and the letter outlines the importance of the function and the function of Board of Health in general, and the recommendation to endorse this correspondence. The second one is also a letter from Alpha to the Ministry of Finance, and I believe this is core to the health and public health function throughout the province. The letter outlines that the financial need for health units and local public health needs to be central to the healthcare system funding, and that the funding for health units has been affected negatively over the years, and during the pandemic there was more functions the funding again, whether it is the formula of funding from the province or the percentage of increase of funding annually, and there is a strong recommendation to endorse this. And I know this is a practice throughout the province as well, from other boards, or recommendation to other boards from their medical officers of health. The last two correspondence are letters from the Sudbury District Public Health to the province to request certain funding for consumption and treatment services. One of the correspondence, the other one is related to community engagement to address food security. Both recommend the recommendation is to receive when they are local to the Sudbury District Health Unit, and that we have historically endorsed for 10 correspondence related to this topic. Search or open questions as always.
You're on mute, Mr. Chair.
We can't hear you, Mr. Chair.
And none of us are that good at lip reading.
Will you try?
The interpretation, like, that's 5 minutes.
He's switching to,
He's having difficulty.
headgear.
There, how's that?
There you go.
We can hear you now, Chair.
I was just having trouble hearing Dr. Era, so I took the headphones off, but obviously it worked in reverse going the other way. So anyway, we have a mover and seconder then to accept the correspondence, moved by Luke, seconded by,
Oh, Mr. Chair.
No, Mr. Chair,
Yep.
you had a question.
Well, it's not a question.
yeah.
I was actually gonna move that we endorse items 1 and 2 there, and then receive items 3 and 4.
okay. Yep. Okay, do I have a seconder then for what Luke is proposing there? Brian Milne. And Luke, you wanted to have a discussion?
No, that was
Oh,
what I was
just-
hoping. Mr. Chair.
Sure. Okay. Okay, any further discussion then on that motion then to accept and to receive the different ones? Then we'll call vote, all in favor? That's carried. Next is media releases.
We have Nelson Phillips in place of Janine Langlois today, Chair.
Okay,
He's on the call.
okay,
Good morning, everyone. Thank you,
Morning.
Mr. Chair, and through you. There are 4 media releases today on today's agenda. On January 27th, Public Health issued a media release to alert the public about 2 fatal opioid overdoses that occurred over a 7-day period in Grey Bruce. This release urged people who use unregulated street drugs to exercise extreme caution and follow critical harm reduction strategies. On February 7th, Public Health advised the public that it expanded its sexual health clinic services to more communities within Grey Bruce. This is intended to fill a gap in other sectors of the health system. Sexual health clinics are now available weekly in Owen Sound and Hanover, twice per month in Wyerton, and monthly in both Kincardine and Southampton. Public Health also issued a media release on February 9th to announce the ratification of a new 2-year collective agreement between Grey Bruce Public Health and OPSU Local 276 ProTech. And on February 13th, a news release was issued that asked for the public's help in locating the owner of a dog that had scratched a person in Owen Sound. And that would conclude the media releases report for this month. Thank you.
all right. Thank you, sir. Can I have a mover and seconder to adopt the media releases, please? Moved by Helen Clare, second by Sue Patterson. Any further discussion on those media releases? All in favor then? That's carried. Next is staff presentation regarding human health development across the lifespan. Dr. Era.
Thank you, Mr. Chair. I will run the presentation to Public Health Manager Yanni Sater, and we have been very, very lucky to recruit Yanni over the past months. She has been doing amazing work. She had experience with Public Health Ontario and other health units, and she's very capable manager in the program. I'll turn it to her to present on the subject.
Good morning. My name is Lami Sadari, and I'm a public health manager at Grey Bruce Public Health. I'm here this morning to tell you a little bit about our priority projects, the human health development. Next slide, please. This is, I think you've gone one too far, Kelly. It's okay. It's okay. It's a life course health development approach, which looks at health from a lifespan approach. So Grey Bruce Public Health has identified 5 strategic priorities. Human health development is one of those matrix projects, along with emergency management, climate change, tobacco and vaping prevention, and sexually transmitted infection. Next slide, please. And so I'm going to talk about, like I said, the human health development. Next slide. Thank you. So human health development is looking at health from cradle to cane perspective. Human health development integrates the concept of health and development processes in a unified whole. And it explains how health trajectories develop over an individual's lifetime and how the risk factors, protective factors, and early life experiences, which we call adverse childhood experiences, how they affect people's long-term health and disease outcomes. And this is why it's so important to use diversity and inclusion when we do this project. Diversity is ensuring that there are different representations, while inclusion ensures that those differences are valued. Next slide, please. Human health development is concerned from pre-birth and even in some cases preconception through the different life stages, through the different social constructs and lifestyles to senior years. It is a concept that acknowledges that the sum of the whole is greater than the sum of the parts. That is, there's greater benefit in doing all than the sum of each of the actions. Next slide, please. So we have divided the lifespan into these 6 major categories. So we're going to look at 0 to 4 years, which is infancy and early childhood, through to school age, which ends at 14 years. We're going to look at 15 to 24 years, from youth to young adulthood, 25 to 44, which is the adult working years, older adults 45 to 65, and the seniors 65 and older. For each of the life stages, we acknowledge biological contributory factors like age and sex, but also the social constructs like gender. And we also acknowledge the huge role that social determinants of health play and contribute to the complexities of health status and outcome. Therefore, for each of these life stages, we will look at equity and diversity, inclusion, and social determinants of health as our values. Within each of the age groups, we'll consider gender, childbearing, maternal status, as well as the SDOH factors that come to play, such as adverse childhood experiences, housing, employment, income, and education. We know that these factors contribute to health and disease outcomes. Next slide, please. So human health development is a public health approach across the lifespans, which aims to improve maternal health, child, youth, adults, and seniors' health under one umbrella. It's a population approach to address the determinants of health, health inequities, adverse childhood experiences, emergent public health issues, public health priorities, and the needs of vulnerable population. It's a population approach that targets subpopulation groups across the lifespan, because we know that by preventing or reducing the impacts of adverse childhood experiences, we have a significant impact on lifelong health and opportunities. The negative experiences in childhood and teenage years may put children at risk for chronic health problems, mental illness, and substance use in adulthood. The risk factors which contribute to adverse childhood experiences and the protective factors which reduce or prevent adverse childhood experiences are at different levels, from the individual level to the family level and up to the community levels. Next slide, please. So in this slide, we looked at the top causes of death in each of those categories. And then we choose a project focus. So as you can see, for the early years, a top cause of death is domestic accidents. And so we're going to be looking at adverse childhood experiences, referral pathways for those who need referral in our programs. And we're also looking at projects in the Indigenous and First Nation communities. In the school age, road traffic accidents is a major cause of death. And so we're going to be working with the land, transportation, and road safety, as well as dental health, which is a priority for us. In the youth, intentional self-harm is a top cause of death, and we'll be looking at vaping in high schools. In the adults, we identified accidental and unintentional self-harm, suicide, road traffic accidents, and accidental poisoning. And for that, our project focus will be the needle syringe program, mental health promotion, and the land and transportation safety. For older adults, 45 to 64, we identify chronic diseases such as cirrhosis and liver diseases, cardiovascular diseases, and lung and bronchial cancer. And we'll be focusing on alcohol consumption awareness, especially as there has been a change in the advice around alcohol consumption and awareness. And we'll also be focusing with our dietitians on healthy eating and physical activity. For the older seniors, falls is a major cause of death. And so we'll be looking at falls and how to prevent those in the older age range. We're also looking at the childbearing and maternal health in terms of postpartum depression and promoting positive parenting. Next slide, please. So a little about the project plan. We have at the health unit a strategic implementation committee, and that committee has finalized its terms of reference. The implementation of the organization's mission, vision, values, and strategic direction is part of its purview. And this committee ensures the organization's programs, partnerships, projects, and people are aligned with our strategic directions. The committee is also responsible for monitoring the organization's key performance indicators against set targets and relating staff's day-to-day work to strategic goals of the organization. So in a way, letting the staff know that their work on a day-to-day contributes to the overall organizational goals. The next diagram, which talks about the Human Health Development Task Group, is a task group that is being put together and will consist of health unit staff that will help to plan and deliver the human health development projects. This staff include health promoters, dietitians, health data analysts, program evaluators, and communication specialists. That task group will report to the Strategic Implementation Committee on the progress of project implementation. We will seek advice and approval for projects, plans, and indicators from the Strategic Implementation Committee, and will determine the roles and responsibilities for the matrix management of the project. In terms of deliverables, we believe that what gets measured gets done. So we're going to be very intentional about what we measure, and so that we give it the attention that it requires. A healthy outcome for people of all ages and diversity in Grey Bruce, a data-driven improvement in health outcomes. In terms of reporting, we'll be doing so using our chosen indicators, and we'll compare this over the long term against similar regions in Ontario, within and as well as against Ontario and across the country. We will use the CCHS and Rufus data that is routinely available to us, and we'll be looking for changes in a positive direction, which can be attributed, at least in some part, to the work that we do with our partners. We'll be reporting using a scorecard. Next slide, please. So many of our projects which we will report on are delivered in partnership or collaboration with our key community partners, whether it be the school board, the police, or the or CAMH. These are the guiding principles of best practice for how we will engage and work with our community partners. We're going to make sure that communication is done early. We're going to engage them very early on in the process, and we'll ensure that our messaging is made clear, that our actions will be rooted in the data that we have. And we'll be giving them periodic updates using a periodic newsletter that's found out to our partners. It's also very important as best practice to set the agenda early on. We'll be transparent with our community partners. We're going to set priorities and build consensus around it, and we'll manage expectations. One of these expectations is that we're not funding or starting new projects. We're reporting on the projects and initiatives that are already on ground. In terms of measuring the impact, we're going to use a collective impact, which is a form of multi-sectoral collaboration for addressing complex and environmental issues, such as poverty, food insecurity, precarious housing. It is situated within the broad frame of collaborative efforts focused on policy change. The collective impact framework has 5 core conditions, which include setting a common agenda, using shared measurements to understand the progress, building on mutually reinforced activities, and engaging in continuous communication, and providing a backbone to move the work forward. So in terms of measuring impacts as well, we're going to develop key performance indicators of success so that we're measuring the right things. An analogy that I would like to use for this is in terms of, if we say that we have nails and we say that we're measuring the number of nails, we will get thousands of nails. However, if we say that we're measuring the weight of nails, we will probably get a fewer but giant nails. And I think that this is what the impact we're trying to have, is those bigger and giant nails. And the last thing I want to talk about is developmental evaluation. So in terms of how we will evaluate our progress, we aim to use developmental evaluation, which is a relatively new concept of measuring change. It's probably about 10 to 15 years old, and so it's newer than the other methods. It supports innovative development and guides emergent and dynamic realities in a complex environment. We don't know we know we don't know, but we try to find out what we don't know. We ask the questions as we go along, and we accept the answers as they present themselves. Next slide, please. And that's all I have for you. Thank you for listening. If there are any questions, I'll be happy to take them.
Sure. Very interesting, Amy. There's a lot of things that you just don't think about. That was, good presentation.
Thank you, sir.
I'm looking to see questions. It's hard for me to see on the screen so just holler out a question. If you've got a question, please just holler it out. I can't see everyone on my screen the way it is here. So do we have any questions, comments from board members?
Yes, Kenneth Craig has a question.
Yep, Ken, go ahead.
Through you, Chair. Thank you for that report. As our Chair said, it gives you pause to think a little bit. Now, the details in it are fine. I'd like to look a little higher level than what was presented today. So I know that Grey Bruce Public Health has a strategic plan in place, and I know that these action items that you've identified and you're going to measure and develop all that, I can't help but think that they're already in the strategic plan someplace. But I'm in the midst of all that. I didn't see anything, as part of childhood, there's vaccinations, then as part of adulthood, there's inspections and food handling courses and sexually transmitted disease clinics, and the Public Health Board does great work in a whole variety of things. And I'm just wondering how this human health development strategic initiative fits into the broader picture? Is it consolidating something that's there already, or is it like it's not information that's new, like we've known this, but what is the importance of refocusing it in the way that that you have done? Like it's not bad stuff, but how is it emphasizing or changing what you're already doing already?
Okay, who wants to tackle that one? Dr. Ayer or Lemmy?
Through you, Mr. Chair, Dr. Zaid raised her hand.
Okay, sorry. Okay, Dr. Zaid?
Okay, sorry, Mr. Chair. Actually, yeah, this is not an old, like new information, but it is important for us after the recovery. We are talking about one of the strategic activities that we will have. So we have a scorecard. The big scorecard of the strategic plan has social determinants of health, community focus, quality and performance, resources and capacity. So these are our main high-level strategic plan. If we go to our strategic goals, we need to focus on 4 areas: sexual health or communicable disease. So if you see our strategic plan, the next after this high goal, there is another plan which is shown as communicable disease, environmental health, human health development, and the 4th one would be human health development, and so it is one of those. So one of the human health development, if we take sexually transmitted, and environmental health. So if we take communicable disease, we have 2 priorities: sexual health, based on the statistics that we have. So we have sexual health, and we have other emergent and urgent diseases. So these are our goals for that part. For social determinants of health, or healthy baby, healthy children, and across the lifespan, we take every age, but based on gender and age, and see what are the main priority in our community. What are the high incidence? So we need to measure and see what is done and how what can be improved. So what is existing and what can be improved. For environmental health, we work on, again, the inspection, it's one thing, and the other thing is climate change. So these are topics or activities that are parallel and work together in that part. I don't know if
so you've taken issues that you've already identified,
yes,
that are already in the strategic plan, and you've pulled them out to measure them in a different format
yes,
to determine areas of success or areas that need improvement.
yeah. We need to measure success, and we need to work on what is not working. Like for every health group, like if we are measuring our data for falls in seniors, and we find that we have higher data. This is as a follow-up from what I have presented last time. So if we have high fall rate in seniors, so we can't really say that, oh, public health is doing inspection. Yeah, we do inspection, we do other things, but this is particular to certain age group, and we exceed the indicators in Ontario for that age group. So we need to work and take that as a priority project. And we work on that, for example, as a matrix project across the organization. As Lani mentioned, we will have communication, we'll have a health promoter, we have a data analyst working together to have a target at the end of a certain timeline. So our target will be to reduce the falls below the level, below certain levels. Yeah, sure. We don't want anyone to fall.
That answer your question, Ken?
That's a start, thank you.
Okay, okay. Yeah. Luke? Yeah.
Well, maybe I can just follow up because reading this chart here that was presented, the chart showing the ages and the top causes of death and the project focus. You might conclude, and I'm not sure I should conclude, that the focus of the project, that the projects will be focused on those specific age groups. So for example, like you read 15 to 24-year-olds, their top cause of death is intentional self-harm, and the project focus is vaping in high school. So that's a little discordant, right? Like because clearly they have a mental health problem in that age group but I'm taking it to mean, and you can correct me if I'm wrong, that what you're creating is a series of projects here that will be delivered at various age groups. And that, so there is like mental health promotion is one of the focuses in here. It's just not next to 15 to 24-year-olds, but I'm assuming our mental health promotion projects will be focused at various age groups and not just the one, right? So, because again, too, like alcohol consumption is a problem, creating a problem for 45 to 64-year-olds, but the problem starting when they're teenagers, right? It's not targeting that specific age group about their alcohol consumption. You're probably too late, right?
It's in Bruce County, but not in Gray.
Wow, yeah, in Gray, you have to talk to their mothers and then.
No, I was gonna say this.
That's a, yeah. So anyway, so maybe some clarity just on how the programs are targeted so that
Yeah.
we're resolving these
Through
issues.
you, Mr. Chairman.
Yep.
The top causes of death, this is something that we identified. So this is something we need to work on. It doesn't have to be a project, a matrix project. But in this age group also, we identified, it's not a cause of death, but there is high incidence of this. So we need to work on vaping in high school. And it doesn't mean that it is in high school that we work on that. So the good thing about the matrix that we have, for example, data analysts, epidemiologists. So we will know that what are the risks, we ask a question, what are the risk factors? What are the protective factors? What are the enablers? So yes, maybe that's going back to ACEs or adverse childhood experience. Maybe go back to families who have smoking normalized or something like that. So we go back, include one in the matrix in this team from healthy baby, healthy children, so that the recommendation for that matrix at the timeline that we need to have some communication or key knowledge exchange to age group, which is families. So our plan will be, so this project will create some activities. So some of the activities will be programmed for mothers or families. So that's how public health ask questions and find answers and create programs.
Yeah, thank you.
Thank you.
Through you, Mr. Chair,
Yep.
just to build on what Dr. Zaid mentioned and go back to the original question about how this fits in the strategic plan at a high level. I shared the slide here where it outlines our vision, mission, values from high level and how that's connected to the different programs. And the program that we're talking about here is to optimize health, human development, and how that fits in the types of metrics for the immediate metrics, the 3 to 5 and the 5 to 15. So again, if there is interest in the high level and zoom in, we can absolutely reference that into our strategic plan. And if this is not enough information, we can strive next meeting to incorporate that in it.
Yeah, just a comment on that. Again, there is a strategic, the scorecard will be the first one at the high level for our approach. Approach is the scorecard. And the strategic goals are the 5 goals. So the capacity, which is in the pink, the yellow one is environment, and the purple is for the healthy human health development. Sorry, the purple will be the preventable disease and injuries. The orange will be the human health development, and then infection control, the last one, the blue one.
Okay, any other questions, comments? Okay, could I have a mover to receive Lammy's presentation? Ian Buddy and second by Kevin Eccles. Any further discussion then on that? That was a great presentation, and look forward to other further updates coming as was presented there. Call vote then, all in favor. That's carried. Next, then we go to the MOH's update, 9.1, Dr. Era.
Thank you, Mr. Chair. I'm pleased to report that the activity of COVID is very low and stable. It remains around 5 new cases per day. On the rate per 100,000, it's around 29. Last week that was recorded, week number 7. The number of outbreaks in Great Bruce in long-term care is 1, which is again a low between a long time since Omicron happened. Hospitalization is still very low and stable. So all around good results for the considering all the factors and being in the winter months. Open to questions, Mr.
Question, Mr. Chair.
Oh, sorry. Go ahead, Brian. Yep.
Thank you, Mr. Chair.
Or Warden Milne.
Dr. Era, I'm just wondering, is the recommendation for vulnerable populations to still rebooster every approximately 6 months? Is that still the general kind of recommendation?
In general, yes, to stay up to date, and that differs from individual to another. Some people might have immune-related condition that requires them to take the vaccine at different intervals, or but in general, that is a recommendation to stay up to date.
Thank you.
Okay.
Question, please, Chair.
Ken, yeah, go ahead. Yep.
And you can tell me whether this question is appropriate or not, Mr. Chair. I'd like to address Dr. Era. You know, there's, rightly or wrongly, I'm not the doctor, there's questions about the origin of COVID-19. And now recently there was a report about a young child in an eastern country that was infected with avian flu, and they said, you know, what's the possibilities or the options? So just really briefly, is there the possibility that this might be another infectious disease that we're facing, or is there any discussion about that possibility of animal-human transmission for that particular respiratory illness?
I'm not specifically sure which case you're referencing, but I can confirm that in general, there's always monitoring for potential new novel diseases. Some of them are zoonotic, where it comes from the animal to the human, and this is around the year. There are different pathogens that are being identified, viruses, and the degree where it becomes potential threat to international situation is different. And the World Health Organization, working with different jurisdictions across the world, has robust ability to identify early, notify early. The pandemic, the COVID pandemic, as an example, the first email I received about potential novel disease was in December, and it was on the same day that the Chief MOH for Ontario received that report. They shared it. You know, depending on the characteristics of the report itself, one can interpret it different ways, and you know, more data is required. But that is the nature of it. It starts small. So in January, I notified the Board of Health in this room, January 2020, that we need to dust off our pandemic plans. I spoke to the 2 counties. You don't want to raise the alarm to a degree where people are freaking out. The technical word in public health is outrage, because outraged people are not going to follow direction, rather enough level of concern with the appropriate information. And to my delight, the Grey Bruce, you know, around the table, the Grey Bruce team delivered on preparation, where when the emergency was announced, we were almost done setting up field hospitals where other people didn't even plan for that, even during the pandemic. So back to the question, there is always a possibility, not a possibility. Definitely, there are different novel diseases coming up.
Okay, that answer your question, Ken?
Yes, it did.
Nope, thank you. Anything else for Dr. Era then on that before he goes on to the opioid update? Okay, Dr. Era.
Chair, through the open situation will be back inside.
Through you, Mr. Chair, I will just share my screen for
Sure.
For an update.
Sure. Yeah.
So the update for February month, again, about the same framework that we are doing: surveillance, emergency response, prevention, harm reduction, and treatment. For the prevention, the locally driven community project that we are leading on youth prevention, focus on primary prevention for youth, is really going very well, and we are now having extension of the project till the end of June, either for the budget and for the delivery, because we had like ethic approval from 2 boards, so it delays the implementation, but the project is really going very well. I shared in the slide also through our committee, we had some we invite stakeholders or collaborators, like for example, Ministry of Health, so that the ministry presented a great presentation on resources that it's like, again, when we start prevention, it's important to be on the same level, all of us, provincially and also locally. So they actually provide great resources from other ministries that part of it we were not aware of. So in the prevention, it's good to have these resources, and we are going to use them, and it's part of the project as well. So that's about the prevention that we are really interested in. For the emergency response, now the data is really consolidated, that we have the monitoring the real-time data from emergency room, the receiving real-time data from paramedics, and monitoring contaminated adulterated drug supply situation. So we had an alert from the chief coroner office about some contamination with material called xylazine, and this is like a horse tranquilizer, not used for humans, and it is really it does not have any effect of naloxone, for example. So we asked a question for the coroner office. I'm waiting for that answer. If any of our local cases has been, we have seen this kind of material. In addition to that, of course, we receive great data now, weekly, monthly, and quarterly. And the good thing that the quarterly, it's a positive sign that our prevention work and boots on the ground on outreach really work, that our death rate reduced for 2022. So that's really a great thing. Of course, it is still a lot of things to be done, and again, it is really a progress, and this work needs to continue. So the capacity for it really needs to work on that. So for the local data, I also share that this is, for example, the data till February 2023, and showing Ontario data versus our data, the Grey Goose data, and where these kind of details are also good informing planning. So where the death situation happens, is it in a retirement home, long-term care, a chronic care facility, hospital, rooming house? So this homeless situation. So this kind of details really help us for more active action that is targeted. For the local situation, as I mentioned, there is overdose alerts, For us, what we know is fentanyl and the methamphetamine. We had unfortunately one death this month for February, and we had 11 reports of suspected opioid overdose. 10 out of the 11 were successful with naloxone, and the help of our colleagues working on the grounds. Our harm reduction team also continue to offer expansion of the naloxone, prevention and overdose prevention promotion in several ways, in addition to training and working on having a letter, memo of agreement or memorandum of understanding with other collaborators, so that we spread the naloxone use across all the collaborators in the community. Also, they have attended some fundraiser events. The night of the year fundraiser on Saturday, they were there. Or continue to work with the SOS outreach team, which is a great team that also work in Sogin and in Wash, and in Hanover and Owen Sound. Multiple other established outreach in Chesley, in Stone Tree, Chippewas of Nawash First Nation, and Wyerton, and again to expand the equitable life-saving medication across the board. So that's about the local situation for harm reduction as well. And for we have also we focus now on the socially complex situation related to drug use. That's the work for harm reduction and our collaboration with our partners. For the treatment, again, focusing on the equity aspect for treatment and working with Grey Goose Health Services across the outreach services to reach out people who suffer from equity issues. So they can't reach the treatment or they can't access it for several reasons. We explore that with this work for boots on the ground. We explore more of the socio-demographic aspect and the reasons for how we really enable people to get things done. Works with partners on outreach approaches and much broader work with higher population impact in mind. So that's my presentation or update for today, and happy to answer any question.
Alan, you're on. Chair, you're mute.
Sorry. Good presentation, Dr. Zayed. I don't mean to put you on the spot. Can you maybe summarize a little bit of our 2-hour meeting prior to this? Just a little bit of direction, maybe, from that meeting, and that it included our local MP and MPPs, and just a kind of an overview of the synopsis of what came from that meeting, and maybe the direction that's going forward there, if you don't mind, just because I think it's really important that everybody realize in your presentation, it's showing things are going well, which it is, but there's also a huge concern out there. And I think we still need to make sure that we're focused on the concern that's out there.
Through you, Mr. Chair, I will just summarize a few points, but of course, Dr. Era can maybe elaborate.
Sure.
So there was a summary about the local or emergency situation of emergency in Sogin, and the capacity issue in Sogin, and how the funding is related to a sort of funding is not like continuation of funding, it's like interrupted or patchy funding. They can't have like it's all about grants. So there is some like the issue there is the complexity of lack of primary care or lack of service that are threatened to stop or to pause by end of the grant, even if they they pass all the indicators of success. So they didn't hear after they get a pilot, the pilot is stopped and they get the grant. So this is a big issue more for the complexity of service in a vulnerable population. The same applies for MIWASH as well. The same thing is about also discrimination and the stigma and all the situation related to the impacting of vulnerable population. The other things is I summarize the situation of opioid crisis and how the situation is related, like how the goods. Maybe the main summary of my presentation was about the challenge, the SWOT analysis. So what are the strengths? What are the challenges, opportunities, and weakness? Again, for the strengths that we have now more intentional interests to know more about the problem and to understand that it is not about delivery of service. It's more complex than that. And we need to understand the layers of complexity and work on them. Like, for example, when we say things things related to adverse childhood experience or more of getting the service done, but we need some work on social determinants of health. The lack of the weakness is related again to the lack of funding for certain specific service related to action. For example, we have the outreach services that had really success, like SOS, but the funding, like we had a project charter and they say keep going, but we don't know if the funding is not sustainable. The opportunity is that we now have more data than before, and we use the data in a better way to understand the situation and act on the situation. So more awareness, and also for the challenges, as I mentioned, challenges system challenge. We don't have like a sustainable system. The other main recommendation was about having the provincial task force, and there was the attendance of from the minister's office for mental health and the attendance of MPPs, and there is really a great interest in presenting in helping. Again, so Game First Nation, they presented the deliverables that they really need to work on, and I think the message was delivered in a very good way to the people who have been attending the meeting. So I stop here, and maybe Dr. Era, if you want to give more details.
Thank you, Dr. Zaid. Through you, Mr. Chair, I echo Dr. Zaid's update. I can just at a high level, we had the honor of hosting a meeting that was called upon by the two communities, First Nations communities in the area. And, I believe the main first step was established, which is establishing trust, establishing connection. There was a call to the provincial level to revive the task force that is based on a letter that we sent in March 2020, and we sent last month. And to my delight, the chief of staff from the ministry attended the meeting. The MPPs and MPs in the area have been engaged and attended the meeting, went over time, which is always a good sign of commitment. So I'll stop there, Mr. Chair.
Thanks, Dr. Era. Nick, you want to just a quick comment on from your corner what your thoughts on it were?
I thought that it was a very productive meeting. I see that there's some follow-up that needs to be done.
And I think that the other thing is that we've all spoken. Now it's time to start putting things into action and start coming out with meaningful and actionable goals. And again, I'll say it loud and clear, a lot of land base and a lot of ceremony, and not excluding the people that are even going through the crisis themselves that don't have that voice. They need to be included in those ceremonies and let that come out. And it's not about photo ops, but it's about getting those right people there. And if they see political parties there and people from the health unit and strong leadership that are supporting them to be able to help them fight this crisis and this battle that they're going through, I think it'll go a long way.
Yeah.
Thanks.
Okay, thanks, Nick. Anything else then regarding the opioid situation, ongoing situation? Ken?
Through you, Mr. Chair, I'm looking at the report on the page that says harm reduction. Second bullet works with Grey Brewers Health Services, CMHA, and EMS. I'm not sure if it was intentional, but South Bruce Grey and Hanover hospitals are obviously missing from this list, and I didn't know whether you had included them in the bigger picture with Grey Bruce Health Services, or whether they are not part of the strategy, or what is there can you tell me what you mean?
So
I'm not trying to, do I need to go talk to the chairman at the Grey Bruce or South Bruce Grey and say, hey, get on board? That's the question that I'm asking.
okay, I'm putting people in trouble then.
Well, perhaps it's nothing personal, but it's a question that's important to me.
Yeah.
Because if South Bruce isn't helping with the effort that is getting in the road, and something needs to be done.
No, they are helping.
Okay.
So Grey Bruce Health Services, meaning Grey Bruce Health Service.
That's on that.
Yeah, but we
Okay.
work more with mental health services. So I meant intentionally the mental health service, which is Grey Bruce Health Services. Under that would be mental health and addiction services in every place. So they are included.
Okay, thank you.
Thank you.
Okay, seeing nothing else on that, Dr. Eric, can you give us the update then on the water?
Excuse me, Mr.
Sorry.
Chair.
Sorry.
I just.
Who did? Sorry,
It's
Helen Claire. Sorry.
If I may.
Yep.
I just wanted to share with the board something that I read this morning that was of concern to me, and I think other members would want to know about it. It was an article reported in Canadian Press this morning, and it reported that Premier David Eby from BC was astonished to find that Health Canada has granted a cannabis company the right to possess, produce, sell, and distribute cocaine. Again, this is Canadian Press, so I am taking it at face value. Health Canada has not confirmed, but the allegation is that Adastra Labs from Langley, BC, has been given an expanded license. I think we all know around the table that Health Canada is looking at a pilot program in BC about harm reduction, decriminalizing drugs. And yes, it's BC, but I think it behooves us in Ontario to keep our eye on this kind of thing. The issue has been up to now the border, that drugs come in from China and Mexico. If indeed we are now looking at growing our own cocaine in Canada, that seems to me that we're removing a barrier for bad guys. It would make it a lot easier for them to go and access this normalized cocaine purchase and then be able to cut it with street drugs and distribute it more easily. So again, I'm just reporting on a Canadian Press item that I saw that I thought would be of interest with regard to the opioid crisis, specifically to Saugeen First Nation. As I pointed out earlier, the people on Saugeen First Nation aren't making their own cocaine. It's coming in from outside of the community. And larger in Canada, it's coming in from outside of the community. And if we're actually now legitimizing it, if Canada is now making space for the federal government to increase a company's profit margin by allowing it to make drugs that are illegal. You can't get a prescription for cocaine. So again, this is just breaking news. So I wanted to just apprise the board members of that. Thank you, Mr. Chair.
Thank you for that. Okay, then we'll, as I say, we'll move on next to then the water drop-off station update. That good news, Dr. Era?
Thank you, Mr. Chair. So in terms of brief background about the subject, there is a provincial program from Public Health Ontario to test the quality of water, specifically used by private wells. And during the pandemic, a number of locations for pickup were discontinued since they were part of the hospital system, and hospitals had policies for realization that limited the number or the reason for people to visit the hospital. So during the time, Health Unit worked locally to secure temporary locations. We secured 4 locations and the Health Unit as a 5th one. And those locations served us over the past 2 years. As the emergency was declared over, the hospitals decided to keep their own policy, exclude the support of this program, so that it's provincial and for many reasons that are internal to the hospital system. So we have been in communication with Public Health Ontario to ensure that these locations that we already have as temporary turn permanent, and to increase a number of locations to cover the gaps that exist in Bruce. To my delight, the last meeting was attended by the Ministry of Health, Public Health Ontario, and the Health Unit, and it turned out that the temporary locations that we already have, there's no intention to add to them from Public Health Ontario. Rather, there is intention to eliminate them if possible, because their operation is hindered by a few factors. So I saw the opportunity to take ownership of that issue, although it's not usually local Health Unit business to deliver this program, and suggest that we design a local program to deliver the service based on local need. To my delight, the Ministry approved in essence, and we are proceeding to design a number of locations to ensure the services provided to anybody in Grey Rouge within 20 to 30 minute distance maximum. And I consider this as a really good success to turn challenge into an opportunity. And we'll keep the board appraised. I cannot not add the thanks to the local political commitment. Mr. Charbonneau, in his capacity as a mayor, wrote a letter, and I'm sure behind the background, in the background, there was communication that supported our ability to get to that meeting and to that result. Thank you.
Good. Thanks, Dr. Ayer, for that update, for that good news moving forward. And Luke, thanks for your part and moving that forward as well. Go ahead, Luke.
Well, I just wanted to make a comment. I really appreciate Dr. Ayer's commitment to it. I think it's not the biggest issue in public health in the region, but a really important one to a few people in my community, in particular, and communities around us, and of course across the region. A lot of well water users, and I mean, Dr. Ayer just ran that right to the ground until it got resolved. So I appreciate it a lot. I know those folks do too. So thanks to you, Dr. Ayer, for getting that done, and looking forward to seeing the plan for how we're going to solve this. A little bit better off in the hands of local public health anyway, because that's how we're going to guarantee that local people get the kind of service they need and deserve. So very pleased with the outcome. I just wanted to express my thanks.
Yeah.
Thank you. You, Mr. Chair, the initial proposal locally will be circulated to the municipalities to get input and approval, and we'll complete the vote on the progress. Thank you.
Right. Okay. Anything else then for the MOH regarding his report at all? Okay. Seeing nothing, we'll move then on to financial report. Kim?
So for you, Mr. Chair, this is the December financial report. At the end of December, we had a surplus of just under $200,000.
A little over 100,000 of that related to the seniors dental program, which had a surplus for most of 2022. As we predicted, we ended the year with a substantially lower surplus than what we had been reporting throughout the course of the year, as there was a lot of spending at year end with the partnerships with the local dentists and insurers. The most recent update I have from the program manager is that they were able to get the wait list down from about 250 people down to 50. So it was an effective strategy that they had in place. The remaining 95,000 surplus that was there at year end is mostly from the programs that operate on an off calendar year, so April to March. So that funding can carry over into the first few months of 2023 to be spent in those program areas. For our mandatory and COVID programs, we covered 1.9 million of our COVID expenses from 2022 with our base funding. Most of our COVID expenses were salaries and benefits for staff working in the 2 COVID programs. We will require about 800,000 in COVID extraordinary funding from the ministry to cover the remainder of our costs. That funding has already been approved and received. So essentially 2022 has been fully funded. Wages and benefits at the end of the year were significantly under budget as they have been all year. And again, that was because of the overtime being significantly reduced from what we originally budgeted for. Our operating expenses were underspent in most areas with the exception of our IT line and our insurance. So we made some investments in some improved software licenses and software last year. And our insurance renewal was higher than what we anticipated it being. Our auditor is currently on site, so they've done some preliminary planning for the 2022 year end, and they'll be doing the rest of the work next week so we can close off our books for 2022. For capital, thanks to the interest rate change, the interest earned on our capital fund is substantially more than it has been in the past. And we didn't have any major repairs in our capital fund for the year. So we had a surplus of 224,000 at year end, which we will carry forward to future years to cover any major building repairs that we may require. And for the Walkerton Dental Clinic, we are currently in the design phase. So the project team is working with the prime consulting to finalize the drawings at the stage. They've involved our IPAC team, and they're doing their assessment and input on the space as well. And the project is currently progressing well, and it's on track with the timelines that the project manager has set out.
Okay, any questions for Kim? Okay, could I have a mover and seconder to receive Kim's report, please? Moved by Luke. Second by Sue Patterson. Any further discussion then on Kim's report? Seeing nothing, we'll call the vote then. All in favor? That's carried. So the only thing I see that we haven't completed before we go in camera will be regarding the executive committee. So Kaylee, I'm assuming we just, if we have a motion then to update the executive committee as per our policy, whatever that policy number is, should be suffice.
Yes, Chair.
Okay, you want to take a minute and then we'll just do that to the precise policy number, or is it hard to pull that up? Or
The only policy that I was able to locate was in regards to being a committee as a whole, and that annually we would appoint an executive committee, but I don't have any specific policy specific to the executive committee.
okay, Helen Claire.
Yes, thank you, Mr. Chair. Through you, I believe that our past chair would be able to speak to this. It is legislated such that it's the chair, the vice chair, and a provincial nominee that comprise the executive committee. It is spelled out, and I have a hunch that Ms. Pattison would have chapter and verse on that because she's so awesome. Thank you.
Not to put you on the spot, Sue.
Through the chair, it is in the terms of reference that it should be the chair, vice chair, and the provincial appointee.
Okay, yeah, I was thinking there was a policy or whatever on it, or there's, as I say, in terms of reference somewhere that where there was documentation on it, but okay, so yep, go ahead, Dr.
You're correct. The policy said that annually the the committee need to be established, and the previous chair is correct in how clear that usually is the composition is. So perhaps in the next review of our policies, we can make it automatic, that it doesn't need to be established with a motion.
Okay. So to simplify it then for right now, if we had a motion on the floor, then that the executive committee for 2023 be comprised then of the myself, Brian Warden Milne, and Helen Clare would be suffice then for 2023. Am I correct in that?
Correct.
Okay, so could I have a mover then, just so we've got that established on the books moving forward then? Moved by Luke, second by Kevin, echoes. Any further discussion then regarding that?
Yes,
Ken?
Chair, please.
Yep.
There's nothing wrong with using your name, but frequently it's a good idea to use the position rather than the name. In the unlikely event of someone's demise or something, when you appoint a chair, they just become the part of the executive committee. So perhaps if that is acceptable to amend the motion to include the chair, vice chair, and a provincially appointed person.
Yeah, that's I think that's better wording. Okay, Kaylee, you're okay with that?
Yes.
Yeah. Kevin, do you have a comment?
Well, I guess just on that, but how many provincial appointees do we have on the board?
Two with one coming.
We have one more coming. And
Any day now, any day now.
We've heard that for the last 3 years.
Right.
That's okay.
Seen it in a lot of, I've seen it in a lot of places. I guess that would be, you know, I'm good with saying it's the chair, vice chair.
Yeah, maybe.
But it's gotta be named. It can't be just the provincial appointee, because my point is, there could be 2 or 3 of those provincial appointees, so, yeah.
Helen Clare?
Thank you,
Okay.
Mr. Chair. I think the wording would be solved if we use the indefinite article rather than the definite article. So a provincial appointee rather than the provincial appointee.
Thank you. I think that covers it.
Okay, so
Mr. Chair,
Kaylee,
with your-
yep, Dr. Ayer?
With your permission, I can share the exact policy that your motion needs to reference, if you wish.
Okay,
So it's coming up on screen. I hope it's not going to be flashing again. And so in the second paragraph, the 2 paragraph annually, again, we can refine the policy to make it stream to be continuously the chair and the vice and the provincial nominee. The thing is, when we have 3 provincial nominees, that decision needs to be made at a certain point.
okay.
Okay,
All right.
thank you.
So going back to it, so the motion then will read that it's the chair, vice chair, and a provincial appointee, and we would name Helen Clare in that then on the motion.
Yeah.
Would make it a lot clearer. Helen Clare?
Mr. Chair, just through you, going to say that this year, because you and I are the only provincial appointees, the issue was made moot. I was the only one available.
Right.
Otherwise, there would be a vote with 3 provincial appointees. There would be a vote. I don't think that my name needs to be in there. Should I die, another provincial appointee would be nominated, and that would be, I guess, Nick, or depending on when my demise should occur. I'm sure that everybody around the board will figure it out. And I subscribe to my colleagues' point that it's better to have the positions rather than the names. Thank you.
Okay, we're going back to then to chair, vice chair, and a provincial appointee.
we'll sort of then move time against.
Yeah.
Yeah, okay. All in favor? Let's move on. That's carried. Okay. Now, now we're, everything else has been looked after then except for in camera. So at this time, we'll give Kaylee a minute so we can stop streaming and go in camera.
See you later.
Yeah, I'll see you all later.
See you, Nick.
Mr. Chair, you need a motion to go in closed session.
Yeah, I need
Okay.
a motion.
It's nice to see you in person.
Okay, we have a motion by Warden Milne, and I think Ken is seconding then that we go in camera. And as per the in-camera agenda, we'll get into that. But anyway, but the motion then to go in camera, we have a mover and seconder, all in favor?
Just a minute, Chair, you
Yep.
better tell us why we're going into camera as per
Yep.
the
Yeah, I
municipal
didn't-
act class says the
I just-
recommendation has to have it.
Just wasn't sure whether when we did that, whether before we go in or whether we were in. So, okay, so the reason we're going in camera is for 3 items. There's items of draft minutes. There's 1.2 is personnel matters, but an identifiable individual, including municipal or local board employees. And the third item is litigation or potential litigation, including matters before administrative tribunals, are the items that we're going in camera for. Okay, so we'll look forward to Kaylee's direction when we can start then the in-camera portion.
You better take the vote, Mr. Chair.
Oh,
I'll go have a look at that. I did look at it, watch it, but go on YouTube and the screenshots anytime you watch.
Then I always say, did I say that? Really? That wasn't done to Mark.
I was always accusing the press of misquoting, but it turns out I'm just standing there taking it.
I knew it was very.
We're live, Mr. Chair.
okay, thanks, Kelly. So we'll reconvene, and I will state that we only discussed matters in camera that were on the previous in-camera agenda. Anything else before this board? Call for an adjournment of our meeting then for today. Moved by Helen Clare, second by Warden Peabody. All in favor? That's carried. Okay, we'll keep everybody posted
Take
on
care, all.
any further developments. Thanks, everyone.
Thank you.
Thank you.
Later this week.